2.5-year-old girl comes to the emergency department because of pallor, lethargy, and decreased urinary output for the past 12 hours. Medical history includes 1 day of bloody diarrhea 6 days back, which spontaneously resolved. The mother reports no recent overseas travel and says everyone else in the family is well. Examination shows that she is afebrile but has periorbital edema, hepatosplenomegaly, and cutaneous petechiae. Urinal analysis shows hematuria and proteinuria. Which of the following statement is most likely true regarding this patient's condition? A complete blood count will reveal thrombocytosis. Initial treatment is corticosteroid. The acute mortality of this condition approaches 50%. The likely causative organism is a gram-negative rod, or the diagnosis is nephrotic syndrome. Let's explain the question along with its answer. A complete blood count will reveal thrombocytosis. Here, a complete blood count will reveal thrombocytopenia, not thrombocytosis, which will be seen in those with signs and symptoms, particularly petechiae, consistent with hemolytic uremic syndrome. Initial treatment is corticosteroid. Regarding this answer, treatment of hemolytic uremic syndrome, occasionally corticosteroid can be supportive with close monitoring of electrolyte and fluid restriction. Corticosteroid are not beneficial in this particular patient but would be first line in a young patient with minimal change disease, which is characterized by periorbital edema and proteinuria without other symptoms. The acute mortality of this condition approaches 50%. Hemolytic uremic syndrome is characterized by anemia, thrombocytopenia, and acute renal failure. Acute mortality is about 5%, and the condition is largely treated by monitoring electrolytes and initiating fluid restriction. The diagnosis is nephrotic syndrome. If we consider nephrotic syndrome, which is characterized by edema and proteinuria, however, for this patient it would not be the case because symptoms of hepatosplenomegaly and cutaneous petechiae will not be present in nephrotic syndrome. For this scenario, the answer would be hemolytic uremic syndrome, which is associated with the infection by the Shiga toxin-producing E. coli. Think of hemolytic uremic syndrome in a patient who has recovered from bloody diarrhea but now presents with the signs of anemia, thrombocytopenia, and intrinsic acute kidney injury. Thrombocytopenia, both from a microangiopathic hemolytic anemia. The course is often preceded by a prodrome of spontaneously resolving bloody diarrhea. The peripheral smear is significant for schistocyte, which is noted by arrow in the slide that we have given. Pathophysiology of hemolytic uremic syndrome will be discussed in detail in another video, but here I will give a very short review. The pathophysiology of hemolytic uremic syndrome centers on the release of specific toxin by the bacteria, which causes endothelial injury. This same toxin additionally causes microangiopathy and thrombosis, leading to the damaged erythrocyte seen on the peripheral smear. The treatment involving monitoring electrolyte and fluid restriction. Mortality is around 5%, with packed red blood cell transfusion and hemodialysis is used in most severe cases. The treatment initially involves monitoring electrolyte and fluid restriction. Mortality is around 5%. In severe cases, hemodialysis and packed red blood cell transfusion is used. If you have liked the video, please hit the like button and subscribe to our channel.